Dear Chairman, ladies and gentlemen, it's a pleasure for me to ask the question or to show you how we might use and interpret FFR in complex scenarios. Maybe we go a step further back and we just try to think about what is really important when we talk about revascularization. And I think we all agree upon it's important, it's crucial that we detect myocardial ischemia in order to establish good symptomatic therapy for our patients, and maybe we might then be able to even improve the prognosis of our patients. And so as an interventional cardiologist, of course, I always have to ask myself the question, is the lesion I'm seeing on a coronary angiogram really producing ischemia? And is this, saying in other words, a lesion that is hemodynamically relevant? And we have learned over the last 15 years that coronary angiography is really not sufficient to answer this question. So, but we are lucky and we have intracoronary physiology, and we have two parameters we can use and we can easily measure in order to answer the question, is a stenosis hemodynamically relevant? So we have on one side the FFR and on the other side the instantaneous wave-free ratio IFR. And basically with both methods we are measuring the pressure in the coronary artery distal to the coronary lesion and proximal to the coronary lesion. And then we form this ratio which is displayed here. The difference mainly is that during the FFR measurement, we measure the pressure over the whole cycle of over the whole cardiac cycle, whereas with the IFR, we are only measuring the pressure in the wave-free period, which is a defined period during diastole. Other differences are, and I think you all know that for the FFR, we need the maximal vasodilation of the vessels in the coronary bed. So we need adenosine and we need nitroglycerin. And the cutoff value has to be found to be 0.8 for FFR. For the IFR, we do not need vasodilation because we measure this at the special time frame in diastole, and vasodilation is not needed, and the cutoff value is 0.89. There is a broad, so what we have learned also over the last decade is that these two parameters of coronary physiology are very conclusive regarding causality, maybe of the pain of the patient we encounter, and that they are also very precise regarding hemodynamic significance of a coronary stenosis. And there is, of course, broad evidence in order to assess intermediate stenosis, and we also know from many randomized trials that intracoronary physiology, or the assessment with intracoronary physiology, is superior to coronary angiography alone. And I would just like to recapitulate this in the next few seconds. So from the FIR trial, we learned that it's really safe not to treat a stenosis in the coronary arteries when the FFR is over 0.75. From the FAME trial, we learned in the next step that it's better to treat only coronary lesions when positive lesions, and not treat all the lesions we see on coronary angiography. And with FAME2, we even learned that it's superior to treat a lesion with an FFR below 0.8 with a stent, with PCI, rather than just treating the patient with optimal medical therapy. And also this was of big debate over the last years. So is it safe even to do these measurements during the acute setting of STEMI? And there is one big randomized trial which has been published in 2017. And in this trial, it has been shown that complete revascularization, which was guided by FFR, is superior to optimal medical treatment, even in patients in the acute setting of STEMI. And finally, we also learned from Sweetheart and Define Flare that IFR is not inferior to FFR. And of course, this is also summarized in the guidelines, which were just published yesterday. So there is clear evidence, a class 1 indication to measure FFR, or, this is new in the guidelines, IFR, when we do not have the evidence already of ischemia in our patient. And then we should use these two parameters in order to assess the hemodynamic relevance of a coronary stenosis. And this was already in the previous guidelines. FFR-guided PCI should be considered in patients with multivessel disease. So I hopefully could already convince you that it seems to make sense to measure FFR and IFR. And now I would like to use the next minutes to share with you two cases, a little bit more complex cases, where we have an additional benefit when we are using FFR and IFR. So the first case is an 81-year-old male patient who presented to our department with stable angina and dyspnea. As cardiovascular risk factors, he had an arterial hypertension and dyslipidemia. The echo was basically normal despite a light diastolic dysfunction. And he was assigned to go directly to invasive coronary angiography due to the fact that, of course, due to his age, the typical symptoms and also the risk profile, he's a patient with a very high probability of having obstructive coronary artery disease. So he did not undergo previous ischemic testing, which is also in accordance with current guidelines. And so here you see his coronary angiogram, and so the right coronary artery looked pretty normal without any significant stenosis, and also the circumflex, which was a rather small vessel, did not have any relevant stenosis. In the LAD, you see a little kink here on the proximal part, and the rest of the LAD looked a little bit irregular, but also no really significant stenosis. And I guess you all might have picked up that there might be a problem here at the ostium of the left main, which you could appreciate here in this LAO cranial projection and also here in the spider protection. So from the angiogram, we suspected that this patient might have a relevant ostial left main stenosis. And I think we all agree upon that coronary angiography in such a case is not really sufficient to decide whether it's relevant or not. And so in this situation, I think we have two opportunities. So we heard before that we have IVUS and OCT. So we could perform intravascular imaging, or we could also go for intracoronary physiology and measure FFR. When we measure FFR in the left main, we have to be careful about a few things. So when the stenosis is rather ostial or really in the proximal part of the left main, we have to be sure that the catheter is disengaged when we do the equalization of our pressure wire. It's basically the same what we have heard before with the IVUS, that we make sure that really the pressure wire is free and we do not have any pressure dumping. So that's the first thing we have to make sure. The second thing is we should think about which vessel, which downstream vessel is less diseased. Is it the circumflex or the LAD? And we should place our wire in the less diseased vessel. The second thing, what we have to do, of course, we also have to avoid pressure dumping during our measurement. So again, when we have placed the wire, we have to make sure again that our guiding catheter is disengaged. And so this also makes it, I would say, impossible that we do an intracoronary adenosine injection for this kind of measurement, so we have to administer adenosine intravenously for the assessment of the left main. And we should always do, no matter what kind of stenosis we want to assess, a pullback wire. And so here you see basically the position of our guiding catheter during the measurement, which shows that it's really disengaged, and you should really make sure that this is the case. And we got an FFR of 0.71, so it's a clear, significant stenosis. So now you might say, what data do we have on FFR in left main? And I have to agree that we do not have a lot of data, but we have one good study with 240 patients published in 2009. And in this study, the 240 patients with left main stenosis underwent FFR measurement. And when the FFR was below 0.8, the patients underwent CABG. And if it was above 0.8, the patient were just, the revascularization was deferred, so they were just observed for 5 years. And what you nicely see in this study is that the survival rate and also the MACE rate was not significantly different. So from this study, we can state that we can safely defer the revascularization of a left main stenosis when FFR is over 0.8. So in our patient, we decided, of course, to treat the ostial left main stenosis. So we placed a stent, did a POT, and you see here angiographically that the stent looked well opposed, and also with the IVUS. And so now I think we could also argue, why have we chosen FFR and why not just doing IVUS? In particular, since there is data that we have clear cutoffs for IVUS measurement. And so there are a few studies showing that when you have a minimal lumen area of 6.0 square millimeters, you can be sure that it's not a significant left main stenosis. For the Asian population, which usually is a little bit smaller, the cutoff would be 4.5 square millimeters. And there is one interesting study from Park and colleagues in a Korean population. So here we would have the cutoff of 4.5 square millimeters. And what you can nicely see, if you only really take into account your measurements by IVUS, you might miss patients that have a significant stenosis, but you can't detect them with IVUS. So here you can see if this is our cutoff of 4.5 square millimeters and the FFR below 0.8, you see here in this area the reverse mismatch. So you miss patients because they seem to have a large enough left main, but actually it's not the case. And why might this be the case? Well, I think the problem with these numbers we get for IVUS is that they are not really normalized to the body surface area. And so if you have a big guy, 6 square millimeter minimal lumen area might be too small, but if you have a small lady, it definitely might be sufficient. So I think to be sure that a stenosis in the left main is significant, I think really that it helps to measure intracoronary physiology rather than just relying on IVUS measurements. The second case I would like to share with you is a 78-year-old male patient, again with stable angina. He presented to our clinic, and he already had a known coronary artery disease with a STEMI in the past in the right coronary artery and PCI in the circumflex. He was a current smoker, dyslipidemia and arterial hypertension were the other two cardiovascular risk factors. Nothing really special on the echo. And again, he was sent directly to invasive coronary angiography and no previous ischemic testing. And here is the angiography of this patient. You see that the right coronary artery did not have any significant stenosis here on the angiogram, and also the circumflex did not have any significant stenosis, and so there was also nothing that we might think of instant restenosis, but you might be easily pick up here this really badly diseased LAD. So there is a long lesion here from the distal all the way up the mid part of the LAD, so a very, very long lesion. And also, if you look very closely, you might also here in this projection see that there might also be a significant stenosis here in the proximal part of the LAD. So, well, when we see this as interventionalists, I think you all agree. We sometimes think, okay, what should we do? Should we just place stents everywhere here in this LAD? And I think in this situation, FFR measurement is in particular helpful for us. So what we did in this patient was the measurement, of course, of the FFR, and so the lowest value was 0.69, so completely clear that this is a relevant stenosis, and I think it's not really surprising. And here in particular, the pullback is really important, and you see this here in the lower part of the slide, that when you do the pullback, you nicely see in this case that the biggest step up in pressure is here in this area, and so it's nice to have co-registration, but if you don't, you can just watch your wire traveling back, and you can exactly see where you get the most pressure increase again when you do the pullback maneuver. And so in this case, it was completely clear that this increase in pressure was here in the mid part of the LAD. So this helps us to identify which part of the vessel is the most diseased, and so what should we treat first. And this is what we did here in this patient. So we decided to place stents here and to post dilatation. And here you see the angiographic result. And then what you should always do in such cases, because you still see it still does not look perfect. Of course, it cannot, because you still see here it's still a little narrowing, and also the proximal part looks a little bit better because we had administered a lot of nitroglycerin and adenosine. But still, of course, this is a very badly diseased LAD. So just from the angiogram, of course, you could stent, I would say, even this part here as well. But do we really want to do this? And so what we decided to do is to measure post FFR. And here you see it's 0.85. So it's still, of course, not perfect. And there is a recent publication showing that there is no exact value you should achieve. But, of course, the higher value you are able to achieve, the better the outcome. But this presentation also showed that, in particular, the LAD usually has less post-FFR values, and, of course, also the longer stents you place, the lower the FFR value is. So let me summarize. I think that the FFR and IFR are parameters which are very precise regarding hemodynamic significance, and also we can use them in a lesion-specific way, which is very different to all non-invasive ischemic testing we have available. And so they are in particular helpful in challenging anatomic situations. And I showed you that this is the case in serial stenosis and also in left main stenosis, but they are also helpful in long lesion where it's sometimes really difficult just by eyeballing decide whether it's significant or not, and also in cases with collateral circulation. So to conclude, I think that every interventionalist should be trained in performing and also in interpreting FFR and IFR. And just to follow also the recommendations, we should routinely perform FFR and IFR in every cath lab. And as I already mentioned, if we are lucky and we have co-registration, this helps us even more to precisely plan the intervention for our patient. Thank you.